I'm embarrassed to recall and admit that when I did my psychiatry rotations, I regularly handed out cigarettes. Congratulations, you got up, you got dressed, here's your cigarettes. You went to group today, here's your cigarettes. You took your medications, here's your cigarettes. And cigarettes, of course, as you know, were a staple of the psychiatric treatment environment. And so all kinds of concerns have understandably evolved in those settings about what might happen when psychiatric facilities go smoke-free, or we more effectively and more appropriately address smoking issues in those settings. And I'm sure your own experiences have revealed to you that many of those concerns are in fact misconceptions and are in fact zombie conceptions. And this whole area of smoking cessation is such that there are a variety of misconceptions, dogmas, prejudicial and outdated attitudes that bedevil our ability to help our patients who are smokers. And these zombie concepts are misconceptions that just don't seem to want to die off. Before I proceed in our conversation, I do want to identify that I've had these kinds of relationships, and it's important that I identify them to you in order that you can assess for yourself the objectivity that I bring to this discussion. So zombies are corpses revived by witchcraft, and zombie concepts are ideas that just never seem to die. And so this is a kind of a shameless attempt to be somewhat contemporary in terms of, popular imagery, popular entertainment, et cetera, just to show that even though I live in Ottawa, I'm still in touch with mainstream society. And zombies are everywhere. Many of you will be familiar with the first-year medical class at McGill, who's quelle surprise. So the first zombie, and I'm sure that this is a zombie that's well understood by you all, smoking is a habit. And when I talk to my colleagues in many other settings, I always try to say, look, I hope that as a consequence of our conversation today, you will commit never, ever again to utter the words habit or lifestyle choice or behavioral choice in any sentence in which the word smoking appears, because to do so immediately reveals you do not understand the fundamental mechanisms which impel and maintain smoking behavior. And as a consequence of a lack of facility or a lack of the grasp of that fundamental concept, you're immediately impeded in terms of the way in which you're going to be able to help patients. At the risk of offending a major religious organization in Canada, I would say that much of what we've done in terms of smoking cessation over the decades has been Presbyterian in nature. Right? If you were just a bit better organized, are you listening to me? How long have you been in my practice? You should be able to stop smoking. My Uncle Charlie stopped smoking, and he smoked 3 packs of cigarettes a day for 20 years. And if he could stop, you could stop, and when are you going to get your... Right? I mean, apologies to Presbyterians. I'm United Church, actually. You can tell the difference. Our prayers begin to whom it may concern. But so, I felt it important that I have reference to some substantial authoritative textbook in psychopharmacology, and you see in that particular volume the evidence that of all of the substances that are available in our community, the one that is likely to induce dependency following very minimal exposure is nicotine and tobacco. Now, there are a variety of reasons, among which there's been the social acceptability, the widespread availability, et cetera, et cetera, et cetera. But this just underscores the important role that addiction plays in this behavior. And most clinicians are blissfully unaware of the fact that outside of the implantable insulin pump, this is the most sophisticated drug delivery device in our community. And hundreds of millions of dollars are spent each year perfecting the design of this device so that it delivers a precise aliquot of nicotine as rapidly and in a way which is misperceived as being pleasurable as possible. And we could talk about front-end lift, we could talk about if I mention free basing, I'm sure most people in this room understandably think of cocaine, but free basing was invented by the tobacco industry. You add ammonia and formaldehyde to the tobacco leaf mixture, the smoke that's produced is more basic, more alkaline, and as a consequence, nicotine is delivered across the alveolar membrane even more rapidly than would otherwise be the case. And we know that the rapidity with which a drug is delivered and sating a need for a drug is an important determinant of its propensity to induce and maintain addiction, et cetera, et cetera, et cetera. And we could take the entire hour talking about the elements of cigarette design. I'm not going to do that, but it is important that we understand that we have the most addictive substance in our community whose use is facilitated by a perversely engineered drug delivery device. And all kinds of marketing misconceptions and fabrications have been perpetuated and promulgated by the tobacco industry as they sought to suggest that somehow you could make these devices safer. The very first filters, for instance, which appeared in the late 60s, early 70s in response to the Surgeon General's report and the British College of Surgeons, Physicians and Surgeons report, were in fact made of asbestos. Now there's a really neat concept in terms of potentiating respiratory health and accentuating the safety of these products. Most clinicians, and I always want to be careful about how I say that in this setting, knowing the familiarity that you have with some of these concepts, until they think about it, are completely unaware in a sense that when you smoke a cigarette, you dump huge quantities of nicotine into the arterial system via the pulmonary circulation. Take a drag on a cigarette and rapidly you amass a huge concentration of nicotine via the pulmonary veins into the left ventricle and wham. And you get this stratospheric surge of nicotine which is delivered through the arterial system to areas in the brainstem where nicotine attaches to a variety of receptors, principal among which we think are the alpha-4 beta-2 receptors, and that ignites a cascade of neurological transmission which produces a release of dopamine and a variety of other neurotransmitters in the forebrain which are associated with a sensation of pleasure, etc., etc., etc. And simply put, the brain structure, the brain function, the brain chemistry of smokers becomes different from the point at which they become addicted to nicotine, which takes about 3 days once you've learned to inhale tobacco smoke. Because then you induce a significant and substantial and persistent upregulation of nicotinic receptors. And from that point on, in order to maintain some semblance of neurophysiological equanimity, smokers require the constant readministration of nicotine. And I know that all of you wanted to learn more about the alpha-4 beta-2 nicotinic acetylcholine receptor, and I promised to oblige. And when nicotine attaches to this receptor, this flower petal-like receptor opens wide, ions flow into the underlying neuron, and that triggers the depolarization of those neurons, and the mechanisms which I simplistically portrayed in the slide before me take place. The other point, and I think I alluded to this, is that most smokers smoke to maintain a certain constancy of nicotine level. And all smokers have kind of this idiosyncratic personalized level of nicotine. That tends to be pretty typical amongst moderate to heavy smokers, but nonetheless there is personal variance. And this slide just shows the rising and falling levels of venous nicotine in association with a metaphorical cigarette. That's the jagged green line. The red line is that comfort zone. The orange and yellow lines represent levels of nicotine produced by the conventional use of fixed-dose nicotine replacement therapy. This particular graph represents somebody who smokes quickly in the morning in order to get their nicotine levels up high. Many of our patients smoke during the night. We don't know that because we make assumptions that people don't smoke during the night. We never ask them about it. And I guarantee you that if you have heavy smokers, many of those smokers are in fact smoking during the night, and it will usually be rationalized as, well, doc, I'm getting up to go to the can. I figure what the heck, I'm up, I might as well have a drag or two. And that may take place several occasions each night. By the way, and just to put this in perspective, that jagged green line reflects mixed venous levels of nicotine. Were we to plot the arterial levels of nicotine associated with smoking a cigarette, they'd be on the ceiling 2 floors above. Once again, just emphasizing that huge arterial delivery of nicotine. I think the other prevailing zombie concept that I think it's important that we address is that somehow the tobacco issue has been addressed. Give yourself a shake pipe, take a deep breath. It's all changed for the better. When you graduated from medical school at some point in the last century, 55% of Ontario males were smokers, and today the daily smoking rate in Ottawa, leafy, jog along the canal, civil servant, high-tech Ottawa is 12%, and the overall provincial rate in British Columbia is 14%, and it's down to 16 or 17% in Ontario. So yeah, a lot of good things have happened. But the patients and clients that you and I see are not representative typically of that general population. And so given that the population has also expanded, there are still millions of Canadians who are smokers, and they are disproportionately represented in all of the clinical encounters and all of the clinical settings that we occupy. And it's essential, if you're giving any kind of an academic presentation, to have a slide invoking the name of the New England Journal of Medicine, and I've got that one out of the way now. But you know, 1 year ago, the New England Journal reminded us again that smokers lose 10 years of life expectancy as a consequence of their smoking. And that if we can help people stop smoking before they reach the age of 40, we basically eliminate 90% of the excess preventable, avoidable, premature morbidity and death. Which is why I think it's important that all of us who see smokers, irrespective of our clinical environment or our clinical settings or perspective, have a responsibility to try to address this in ways that are sensitive, ways that are sophisticated, ways that are strategic. And certainly the mental health environment is no exception. And in fact, that same issue of the New England Journal, this is a very rich academic presentation, there are 2 slides from the New England Journal of Medicine, points out that those who care for smoking-related illnesses, and psychiatrists were particularly identified in this group for reasons that I think will become clear in a moment, should be doing more to stimulate quit attempts. Well, in the Coles to Newcastle category, now I'm wading even deeper into trouble because I know that you're aware of these kinds of relationships and this kind of data, that those with chronic mental illness or psychiatric conditions have a life expectancy in Canada that's 25 years less than that of other Canadians. A staggering discrepancy. And tobacco addiction is a major contributor to that premature mortality. And we know that because of the existence of psychiatric comorbidities, that rates of smoking are much higher in this population. 44% of all tobacco products in North America are said to be consumed by individuals with psychiatric comorbidities. And as one of my colleagues rather ironically pointed out at some point, it may even have been Peter Selby, the tobacco industry is the only organization, entity, or grouping in society that has not actively discriminated against the mentally ill. And indeed, there is good evidence to suggest that the tobacco industry at certain points specifically targeted it as marketing for certain of its products to those with psychiatric illnesses. And there is absolutely no question that the tobacco industry knew more about the neurophysiology of nicotine addiction and related topics and kept it buried because it never published it in the scientific literature for decades. And some have suggested that they retarded the whole development of neurophysiology in those areas as a consequence of the secrecy with which they acquired this particular knowledge. From time to time, people talk about the population of smokers today being a population of hardened smokers. And we can have elegant debates about whether or not that's a real phenomenon, but I think it is the case that certainly in my setting, and I would suggest in yours, that those of the patients or clients that we see who are smokers are very different than the smokers that we saw 20 years ago. And by and large, the transformation of the social and public environment, the proscription of tobacco advertising sponsorship, et cetera, all have had a very profound impact upon smoking rates in the community. And those for whom cessation is more difficult, therefore remain smokers and warrant and merit our particular assistance. And just to identify the relationships which may support smoking in such populations, the slide on the left, or the graph on the left, pardon me, shows that the general population, only a minority are smokers. In a population of those with a history of depression, a propensity for or current depression, a majority are smokers. And you know, if you were using the Presbyterian approach, you would say, well, this is because these people have so much time on their hands. Perhaps they don't have the requisite skills to get their ducks in a row the way that other people might have, and it's the only pleasure that remains, and we should, you know, and blah, 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 which is, again, I think an inappropriate perspective. When we begin thinking like clinicians and scientists and seek to deconstruct this relationship and identify if there are contributing mechanisms, we begin to find some interesting facts. If you look at the slide, or pardon me, the scan on the left, which is that of a non-smoker, you see that something is lighting up the kidneys, the liver, the heart, and the brains of those who are non-smokers. Something is absent in those same structures in smokers, and that something is monoamine oxidase. And most clinicians are completely unaware that hundreds of times a day, smokers are self-administering small doses of monoamine oxidase inhibitors. And so as a consequence, they are self-medicating, if you will, and deriving some benefit in terms of their depressive symptoms as a result of this phenomenon. Conversely, when individuals stop smoking, when certain individuals stop smoking, it's quite reasonable to suspect or predict that symptoms of depression might emerge. Typically, when those symptoms do emerge, the emergence of those symptoms has been attributed to the agent that has been used to help people stop smoking. Clinicians all across this country know about the relationship between grapefruit juice and the metabolism of statins. Notwithstanding, you've got to drink tanker loads of, well, not quite that much. But most clinicians, most family physicians have no idea about some of these fundamental relationships. Why should they have to know about this? This is a habit. And if their patients were just better organized, they would do something about it. And so we've not felt any kind of investigative or scientific responsibility in trying to understand some of these kinds of processes. And similarly, those who are suffering from schizophrenia have prodigious rates of smoking. And they do so because when they stimulate the alpha-7 nicotinic receptor, that has the effect of blunting the intensity, the frequency, the volatility of the auditory, visual, and other stimuli that constantly assail and destabilize them. And so they smoke furiously in an attempt to derive some benefit from the stimulation of that receptor. But paradoxically, there are other products in tobacco smoke that induce enzymes of the cytochrome P450 type pathways that accelerate the metabolism of a whole array of medications. And again, most clinicians are unaware of this. And that has particular relevance in those that are dealing with psychotic syndromes, because some of the major antipsychotics have their metabolism accelerated by smoking behavior, so that when smoking stops, it may be that levels of those medications rise and give rise to a greater frequency of side effects. But there's an even more prosaic relationship. Cigarette smoking stimulates the metabolism of caffeine. So if you're one of those Canadians who has 4 or 5 double-doubles a day and are a smoker and stop, over the course of a few days, your 4 or 5 double-doubles are going to start to feel to you like 8, 9, 10, 12 double-doubles, because caffeine's metabolism is no longer being stimulated. And that, of course, leads to some very practical considerations in terms of facilitating smoking cessation by reducing caffeine intake, et cetera, et cetera. I guess the other very relevant zombie that one would like to plunge some lightsabers into in terms of our conversation today is that psychiatric patients can't stop smoking. And clearly, we understand that most of our patients with these challenges would like to quit. And when you actually start to apply cessation strategies, the quit rates are only slightly lower than those of the general population. And indeed, the work that has emanated from this institution has pointed out that smoking cessation interventions using standard pharmacological and behavioral approaches can be used very safely and very effectively in mentally ill and addicted tobacco smokers. And so that adopting smoke-free policy goes hand in hand with the recognition of the responsibility to assist our smoking patients, and the Armageddon that everybody predicted would happen when you took tobacco out of psychiatric facilities just doesn't occur. And that's an experience that has been replicated in settings and reported on in settings from around the world. And so I think this reflects the kind of leadership that reflects the basis of the kind of leadership that your institution has provided. At the risk of being shamelessly self-promoting, I just want to point out that one of the things that we found in our environment that can be absolutely of great assistance in terms of helping patients stop smoking is developing some systematically applied protocols that allow smoking cessation interventions to be delivered. You know, we used to go through this annual existential crisis in our smoking cessation program at the Heart Institute, because people would get together and say, gee, people are canceling, they're not showing, canceled this, and and we're only seeing a couple of 100, 300 patients a year. And then one day somebody said, well, you know, we see 2,500 to 3,000 patients who are smokers every year in the Heart Institute on floors 3, 4, and 5. And guess what? They've got diminished renal function, their blood sugar's a little out of whack, their cholesterol levels are elevated, or their blood pressure is high, lights flash, bells ring, teams of residents descend upon them, and the latest hypertension control and dyslipidemic management strategies are applied, and if they're not, heads roll. And what do we do about smoking, which dwarfs those other cardiovascular risk factors? Well, it might have been a serendipitous, gee, I see you're a smoker, gee, have you ever thought about, perhaps you might want to think about Have you talk about it with your family physician the next time, if you got one? And indeed, if you go to most Canadian hospitals still and ask, gee, how many of your patients admitted to your hospital are smokers, given that this is Canada's leading cause of preventable disease, disability, and death? And there's usually an embarrassed silence. And if it is collected, it's collected in a haphazard manner and leads to misperceptions. So out of that came this whole thing, which eventually evolved to be called the Ottawa Model for Smoking Cessation, which just meant that we do ordinary things extraordinarily well. We identify the smoking status of all patients. It has to be documented. The protocols are in place. This isn't a nice, it would be nice if we did. This is part of what happens. We get your phone number, your residential address, and we also inquire, not are you a smoker, but have you used any form of tobacco in the past 6 months? Have you used any form of tobacco in the past 7 days? And then and only then do you get an accurate representation of smoking status. Because many of our patients decided 48 minutes earlier on a gurney in the angiography suite that they were now a non-smoker. And so their answer is not intended to deceive, but an opportunity to affirm that new naively acquired non-smoking status. That identification and documentation then triggers an offer of assistance involving counseling, behavioral support, and pharmacotherapy, and then we follow these patients up in some ingenious ways. But it's all about, and I repeat myself, doing some ordinary things extraordinarily well. And as a consequence, we were able to show that we were significantly improving our rates of smoking cessation. We also spent some time disabusing many of our colleagues, many of whom were firmly entrenched in the Presbyterian approach to smoking cessation, that they could efficiently and effectively begin to address this issue in as little as 26 seconds. By simply saying, you know, Mrs. Brown, since you've had your heart attack, it's important we both understand that the most important thing we can do is to help you stop smoking. Boy, I know how difficult that can be, and I'll bet you've struggled with that in the past, but here at the Heart Institute, we've got a process and some programs which I think will be very helpful to you. We're going to offer you assistance in that way, and I hope you won't ever hesitate to ask for our assistance. And this is just so important. I'm going to inquire about this every time I see you from now on. End of story. 26 seconds or less, I hope. Right? As opposed to, don't you want to see your children graduate from high school and have you no idea what's happening to the endothelial surfaces of your major blood vessels, to say nothing of autoregulation of your coronary vascular, blah, 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 right? Fact one, the overwhelming majority of Canadians who are smokers know why they shouldn't smoke. The majority don't want to be smokers, and a very substantial proportion will make one or two personal private quit attempts each year, 95% of which will fail. So rather than providing interactive CD-ROMs and colorful posters and fridge magnets and providing you with information about reason number 194 why you should stop smoking, we as clinicians should actually be providing assistance in a very sympathetic and strategic kind of manner. So with that kind of as a background, let me continue to just talk about some of the approaches that we use and that are in use in terms of being able to help our patients stop smoking. And I want to specifically talk about pharmacotherapy, and I want to take the opportunity to kind of do a 10,000-foot flyover, knocking off some zombies along the way, hopefully. And all of the guidelines speak of the ability of cessation pharmacotherapy to assist with smoking cessation, and we have 3 first-line or front-line therapies, and I'm just going to take a few minutes to talk about each of them and hopefully dispel some very substantial myths that occur. So let's talk first of all about nicotine replacement therapy. Been around for a long time. The whole rationale, as we'll see in a moment, is that if you can boost nicotine levels to or get close to that kind of comfort zone of nicotine that people want, then when their nicotine levels fall, they don't fall as far as they would, and so therefore the craving and withdrawal symptoms don't predominate and don't impel them to seek out another cigarette. So very solid kind of rationale. The products are available without prescription, and in order of rapidity of delivery of nicotine, go from the patch, which is the slowest, to a nicotine spray. All of these products deliver nicotine through the venous system in a slow or a much slower manner than would be the case if an individual inhaled a cigarette. So either through the skin in the case of the patch or through the mucous membranes of the mouth or the throat. And so the comparison in terms of the amount of nicotine that's delivered to a patient using nicotine replacement therapy and smoking a cigarette is night and day. And that's why I go to such lengths to talk about when you deliver nicotine by smoking, you're delivering it via the arterial system, not the venous system. And so all kinds of misconceptions about the safety of nicotine have arisen, and we'll try to knock those out of the park in just a second. So advantages, yeah, available, relatively inexpensive, doesn't require a prescription. Shortcomings, used very badly by clinicians and by the public at large. We still get messages from patients who say, well, my doctor said he wants me to use the patch, but only for 2 weeks because he doesn't want me to get addicted to the patch. Okay. McGill graduate, obviously, right? But so there are all of these kinds of zombie concepts out there. And people do not appreciate or understand that, like every other medication, we should manage smoking cessation pharmacotherapies by providing an initial dose, monitoring the response, adjusting the dose in proportion to the response, and then adjusting the duration of therapy until the desired endpoint has come along. Right? We don't treat all ankle fractures by putting a plaster cast on for 6 weeks. And then when the patient comes back and you say, I'm taking the cast out, they well, hang on a sec, my ankle's killing me, I can't possibly walk on the ankle. Doesn't matter. Fractures heal in 6 weeks. The cast is coming off. And yet that fixed dose paradigm of nicotine, you know, we're going to have 4 weeks of this and 4 weeks of that and 2 to 4 weeks of that, and then you should be able to do this yourself. This is Presbyterian light. Okay, it's kind of, we're New Age Presbyterianism. But so, you know, I think with a bit of hyperbole, I've made that particular point, because the standard dose of nicotine replacement therapy will not meet the comfort requirements of nicotine for many of today's smokers. And so you should be prepared to adjust the dose. And so our standard orders for nicotine replacement therapy at the Heart Institute say, for every pack a day that you smoke of cigarettes, you get one 21 milligram patch. And if you're a 4-pack a day smoker, you're probably going to get 3 and a bit patches, maybe 4, and the use of an inhaler. Right? We are not afraid to appropriately manage nicotine craving. In exactly the same way, we are not afraid to take on hypertension or dyslipidemia. And we don't say we're going to treat your hypertension with hydrochlorothiazide 50 milligrams a day for 4 weeks, then 25 milligrams a day for 4 weeks, and then 12.5 milligrams for the final 2 weeks of your hypertension control attempt. Bring you back, measure your blood pressure. You're still hypertensive. Please go away and think more seriously about when you're prepared to make your next hypertension control attempt. And this is kind of a confessional for me, because I spent half a decade going around the province when NRT first came into being, telling people this is how you did this, right? You just needed to ensure that their moral fiber was reinforced. So the important concept here is that I think when we're talking about smoking cessation, we're trying to help people open a doorway onto a smoke-free future, and sometimes that doorway has to be held open much, much wider and much, much longer. And at the risk of seeming to be very simplistic, cessation pharmacotherapy, as much as it takes, for as long as it takes. And I have no qualms in seeing a patient who's 12 months post-heart transplant who says, gee, for the first time in 38 years, I'm smoke-free, but if I take these 2 patches off, man, the urge to go back to smoking is so. Fill your boots. Keep putting a patch on your left shoulder, put your nitro patch on your right shoulder, we'll see you in 3 months. And by the way, I don't want you to believe that this is kind of standard practice or necessary in every case, but it happens. But when I use the heart transplant example, people's heads always kind of, oh yeah, oh, heart transplant, big deal, right? Well, if it's best practice for an individual whose life expectancy may be in single digits, why is it not best practice for a 22-year-old woman who's trying to stop smoking at the same time that a clinician is providing her with birth control pills, right? And P.S., again, most clinicians are not aware of the things that they do on a daily basis which can alter the rate of nicotine metabolism, which we feel is an important determinant as to whether you're likely to become a smoker and as to whether you're likely to have difficulty stopping smoking. You place a woman on a birth control pill, her rate of nicotine metabolism may double. When a woman becomes pregnant, her rate of nicotine metabolism may triple or quadruple, or even more. And now we begin to have some reasons as to why it is that those seemingly insightful, determined young women who always looked us squarely in the eye and said, when I get pregnant, I'm stopping smoking, I can get. have such difficulty with this? And I think these kinds of concepts speak to our failures over the last few decades to really understand some of the fundamental underpinnings of smoking behavior and the way in which smoking behavior and the administration of all of the products in tobacco has an impact or an effect on other clinical conditions. So we are quite comfortable titrating the therapy, titrating the dose and the duration, and increasingly using combination therapy to help smoking cessation. So, as you might guess, in our setting, one of the biggest zombies that constantly assails our institution, although we don't let them into the perimeter anymore, are the zombies that say you can't use NRT in cardiac patients. So hold your breath. If you're prone to seizures, the next rapid display of slides may induce some problems. But the slides go like this. The safety of NRT in cardiovascular data is supported by data from randomized trials, efficacy studies, observational and clinical trials in patients suggest that nicotine does not increase cardio. The use of nicotine patches does not cause aggravation of myocardial ischemia or arrhythmia in coronary patients and can be used as a method to promote. High dose, even with smoking, causes no short-term adverse effects. The use of NRT is not associated. Have I showed you enough slides? And unfortunately, this is what it takes to kill off zombies, because you kill off one zombie and there's 16 of them lurching towards you, and so it's necessary to kind of have this scattergun approach. And perhaps this is the best evidence that I can share with you. And this is our own clinical experience, although I'm embarrassed to say it's 7 years old now. But if you look down in the bottom right-hand corner, these are individuals admitted with an acute cardiac syndrome. That is, they've got unstable angina or they've got a fresh, within an hour, myocardial infarction. And these are individuals who come to our coronary care unit, and at that time, 70% of those individuals who are smokers were getting NRT applied in that setting with no problem whatsoever. Except that a reduced rate of prescription of hypnotics and anxiolytics, a reduction in behavioral challenges as people rang their bell constantly, threatened to sign themselves out, were irritated and obnoxious and uncooperative with nursing staff because they were experiencing nicotine withdrawal. And whether you're admitted to hospital with a fractured femur or a premature labor or an anterior wall infarction, if you're a smoker, quite predictably, it's likely that you will experience nicotine withdrawal. And so now that hospitals and healthcare facilities are smoke-free, we have to be prepared to ensure, if for no other reason than to facilitate the comfort of our patients and en passant facilitate the compliance with treatment to treat nicotine withdrawal. And developing protocols and standard orders will rapidly allow clinicians to become very comfortable and very competent and with the comfortable, competent, and confident with the administration of nicotine replacement therapy. And all of those zombies will flee. When we talk about nicotine replacement therapy, I just want to make an observation about the e-cigarette issue. Let me be unequivocal. There is absolutely no question that if you use nicotine as the result of its delivery in a vapor as opposed to its delivery from smoke, it is infinitely safer. And there's just no question that as a harm reduction technique, e-cigarettes, or whatever they ultimately will be called, show unbelievable promise. There are, however, a number of questions. And these are questions that we need to answer, and we need to answer quickly, because we should not impede the ability to deliver a harm reduction approach because of some bureaucratic inertia that might surround the regulation of these products. But there are questions to which it's still early days. Does the use promote cessation, or does dual use of both e-cigarettes and conventional tobacco products continue? We can be assured that the tobacco industry, now that it's acquiring these companies, is not the least bit interested in smoking cessation as the use of these particular products. And certainly in jurisdictions where they're still able, they will use all of their tendencies and behaviors from the past to accelerate the marketing and the utilization of these particular products. So that's something to be considered. And we also have to be concerned, although the emerging evidence suggests on one hand, on one side of the Atlantic, that there is no increase in non-smokers using these particular devices, whereas there is evidence from this side of the Atlantic that in fact the number of adolescents who are non-smokers who have started to use these products has actually significantly increased. So more to come. And Chris Bullen's paper in Lancet at the end of the year is one of the few studies that have examined the use of these devices in smoking cessation. More are coming out, and we have to follow them very carefully. But certainly their results were that these were only modestly effective at helping patients stop smoking. Nonetheless, I think particularly as we change our approaches to smoking cessation and employ reduce to quit kind of strategies and so on, that the use of these devices perhaps in association with other cessation pharmacotherapies offers us opportunities that we haven't quite thought about yet. And so there's need to be examining those issues in the future. I'm going to make a couple of comments about bupropion, only to note that this drug serendipitously was found to be able to help people stop smoking. There are contraindications, which you're probably far more aware of than most clinicians, to the use of this agent, which is obviously fundamentally originally an antidepressant. But many patients will report that taking the conventional doses of these products, they don't kind of like the way that they feel, or that they have a dry mouth or a skin rash. Well, in any other area of clinical practice, when patients have side effects which are dose-related, we adjust the dose. And reducing the dose of bupropion in the face of these kinds of side effects generally addresses the side effects without significantly attenuating its ability to help or maintain smoking cessation. Once again, that point about titration, and when bupropion was first arrived, it was shown in contrast to nicotine replacement therapy to be very significantly more efficacious, and when used in combination, the first hints about combination therapy was more efficacious again. Final comment about an agent, Varenicline, which is a modification of a naturally occurring substance that is found in the leaves of a shrub which grew in Western Eurasia. During the Second World War, people smoked the leaves of this shrub as a tobacco substitute. Post-Second World War, the Iron Curtain Eastern Bloc pharmaceutical industry used the leaves of this shrub as a smoking cessation aid. The active ingredient, cytisine, not cytosine, cytisine, binds to the alpha-4 receptor, but not well. But if you modify that cytisine structure, you get Varenicline, which binds avidly to this particular receptor, except that when it stimulates this receptor, the receptor only opens part way. You get overall less flow of ions, overall in aggregate less depolarization of underlying neurons, and therefore in aggregate less release in the forebrain of dopamine, and et cetera, et cetera, et cetera. But smokers perceive this as, I don't really feel like I need a cigarette because I'm feeling okay. I got nicotine receptor stimulation producing dopamine and other transmitter release. And by the way, this is occupying that particular receptor site. And so if I do smoke a cigarette, I don't really kind of feel that So now we are able to use, if you will, molecular biology principles to address some of these issues. Now, that is not to say that this is the answer, but we are certainly a whole lot further along the road than we were in the past. The most common side effects of Varenicline and anything which stimulates nicotine receptors are nausea and sleep disturbances. Why? Because you've got nicotine receptors in your gut. If you stimulate them constantly, you're going to get nauseated. In exactly the same way, if you chew nicotine gum very avidly and swallow the saliva, nausea will follow. So if you're using a systemic agent, which is omnipresent around the clock, you're going to have perhaps nausea. You're certainly perhaps initially going to have some sleep disturbances, some insomnia, some unusual dreams, because those nicotine receptors are not used to being stimulated during the night. Those symptoms, generally pass fairly quickly. In fact, it's kind of intriguing. Many of the responses we get from patients on Varenicline are, yeah, I'm having unusual dreams, but you know what, they're kind of cool, and I can't wait to go to bed at night because I wonder what's going to appear this evening. But then there were the questions of neuropsychiatric and cardiovascular issues. And so clearly one of the zombie concepts that has persisted is that varenicline causes psychiatric problems, despite the fact that following the initial pharmacovigilance type signals, which are unbelievably sensitive but not specific, if you look at the use of varenicline in large populations or in communities where varenicline has been used for a considerable period of time, you find that there is no evidence to substantiate the view that these cause psychiatric disorders. And that evidence comes from a variety of sources in a variety of communities. The U.S. military health system published this in late 2012, comparing varenicline with NRT patch, no increase in neuropsychiatric hospitalizations, overall reduced rates of inpatient and outpatient neuropsychiatric diagnoses, consistent with studies using NRT and varenicline uses in other settings, showed no increased risk of self-harm, depression, et cetera, et cetera, et cetera. At this point, let me digress. I live and work and play in a cardiovascular setting. I am old enough to be able to remember when statins, which are now the mainstay of the management of coronary artery disease, were first introduced. And I remember being in Toronto at the Toronto Conference Center and hearing very learned clinicians and scientists say, hang on a second. There's evidence that statins are making people depressed and having suicidal thoughts and suicidal ideation. And we better be, you don't hear a single word about that now. Not because we're reckless in our use of statins, but because it's a common phenomenon when products are introduced that these pharmacovigilance instruments pick up these kinds of signals, which are frankly more noise than signal. So I think one can clearly say that the evidence about the concern of varenicline causing psychiatric problems is now dissipating. This zombie had its origin in Canada because in an article which appeared in the CMAJ, which was purportedly a meta-analysis of a sort, the authors suggested that the risk of cardiovascular events in a meta-analysis of studies using varenicline in cardiovascular patient populations was 0.82% in the placebo group and 1.06% in the varenicline group. Now, in most cardiovascular pharmacology clinical trials, an adverse cardiovascular event, and this can just include irregular heartbeat for 2 seconds and the whole pantheon of this is pretty low. But this was interpreted by the authors as a 72% risk of serious adverse cardiovascular events in those that used varenicline. Why did this exercise pipe so much? Well, because I was involved in what was the largest single trial of varenicline in a cardiovascular setting. The largest group of patients in this meta-analysis came from our trial, and all of our cardiovascular side effects, notwithstanding that this trial wasn't powered to be a safety trial, all of our cardiovascular side effects were independently reviewed. And we found no signal whatsoever in that particular meta-analysis, so we were kind of a little perturbed by this. But fortunately, the British Medical Journal 1 year later published a more complete, more appropriate meta-analysis looking at the risk of cardiovascular side effects from varenicline and concluded no significant increase in cardiovascular serious adverse events associated with varenicline use. So there's a lot of, no pun intended, smoke that swirls around the academic discussions of smoking cessation pharmacotherapy, and very often it takes some time for the smoke to clear, and that evidence just continues to accumulate. Well, I see that time is coming to an end, and so let me kind of cut to the chase. If we're looking at evidence of medication effectiveness, we see that the single most efficacious single agent, the most efficacious single agent is varenicline. On the other hand, combination of various forms of nicotine replacement therapy is equally, if not more, efficacious. And so we have the good fortune of being able to have access in our settings to pharmacotherapy for cessation, which is proven effective and can be used to help our patients. And not only are these interventions clinically effective, but if you look at cost effectiveness per life year saved to treat dyslipidemia can cost up to $200,000. And for the treatment of hypertension, up to $26,000, $27,000. P.S., and my cardiology colleagues are always kind of surprised, It doesn't matter if you've got your patients at Canadian consensus guideline levels of hypertension or dyslipidemia if they are still smokers, because they will not derive any of the benefits that clinicians assume will benefit through the fastidious management of their hypertension and dyslipidemia. So the tobacco issue has been addressed. That zombie comes back again. We see that data. When asked how we can best help our patients who are smokers change their behaviors, my colleague, Dr. Bob Reed at the Ottawa Heart Institute, is famous for saying, by changing our own. By continuing to do what we've done for decades in terms of smoking cessation isn't going to make a difference whatsoever. By being innovative, sensitive, strategic, by beginning to apply systematic approaches using well-established clinical protocols, by taking advantage of the fact that as a consequence of CAMH's leadership all across this province and across this country, we have healthcare professionals from an array of disciplines who have been trained in approaches to smoking cessation. We can transform professional behaviors, and as long as the apparatus, the schemas exist within an institution that allow those individuals to express those professional skills, we can dramatically change institutional practice and in the process enhance patient care.